Hi everyone, welcome back. In this video, I'm going to be talking about jaundice. I'm going to go through a diagnostic algorithm, how to work through a patient with jaundice when you have a test question that presents a diagnostic challenge. I recommend though first you watch the video on bilirubin metabolism. You need to understand all the different steps that are involved in that so that you can figure out how to distinguish the different causes of jaundice. So if you already done that, then let's get started. All right, so let's first start with an overview of bilirubin and hyperbilirubinemia. So where does bilirubin come from? It's produced inside the body from the breakdown of red blood cells. Their hemoglobin gets broken down to heme and globin, and then the heme gets further broken down into bilirubin. And this initial form is obviously not conjugated yet, therefore this is known as unconjugated bilirubin. And this unconjugated bilirubin literally serves no purpose in the body. And in fact, if it accumulates and if we don't get rid of it, it can actually become toxic. Therefore, the body has to somehow get rid of it. And the problem with that is that it's not water soluble. So in order for us to remove it, first we have to move it onto the liver here in step 2 so that it can become conjugated. Once it gets conjugated in the liver, it becomes conjugated bilirubin, which is now water soluble. And that means that we can eliminate it in step 3 here by excreting it in the liquid environment of bile into the GI tract, where it's then removed from the body through feces. And this is the process of bilirubin from where it's produced to where it's conjugated and then it's eliminated. Now, this is all normal. However, when we have a problem with too much bilirubin in the body, so we can't get rid of the amount that we're making, this is going to lead to hyperbilirubinemia, so high amounts of bilirubin in the blood, which is indicating that there's too much bilirubin in the body. So hyperbilirubinemia is high levels of total bilirubin, which of course is made up of the unconjugated form and the conjugated form of bilirubin. And here I just want you guys to take away that basically the only things that are going to lead to hyperbilirubinemia are if you have one or more issues with one of these processes that we talked about. So if you have a problem with production, for example, number one, if you have too much production, like in hemolytic diseases, this can lead to too much bilirubin because you're producing excess bilirubin. Or if you have a problem with step 2, which is conjugation, so number 2 here, if you have impaired conjugation, for example, if our UGT enzyme, which is the enzyme that's in the liver responsible for conjugation, is deficient, then we can't conjugate the bilirubin and therefore we can't get rid of it, and that's going to lead to hyperbilirubinemia. And finally, number 3, even if we're able to produce a normal amount and able to conjugate it, if we have a problem with step 3, which was excretion, so if we have impaired excretion, such as an biliary tract obstruction, then this is going to lead to hyperbilirubinemia. So mechanistically, this is a good way to think about what are the causes that lead to high levels of total bilirubin, aka jaundice. All right, so now let's wrap up our overview of hyperbilirubinemia. Let's talk about some clinical findings. And these are all going to be caused because you have too much excess bilirubin that's going to now accumulate inside of the tissues. So the main symptom is going to be jaundice, which is yellowing of the skin. And one of the earliest and most reliable signs is scleral icterus. So this is literally jaundice or yellowing of the sclera, which is the white part of the eyes, as I've attempted to show in my drawing here. And then finally, in infants, an important diagnosis to be aware of is kernicterus. This is when you have the bilirubin depositing in the brain. And the reason this happens is that sometimes in infants, they get really high levels of unconjugated bilirubin. And what you just learned is that unconjugated bilirubin isn't water soluble, which means that it's lipid soluble. And the problem with lipid soluble is that it can cross the blood-brain barrier and deposit into the brain, and it can cause permanent neurological damage and even death. So this is definitely one to pay attention to in infants. And I talk more about kernicterus in my video on neonatal jaundice. Now, the main differential diagnosis for actual jaundice is going to be something known as pseudojaundice. So this is yellowing of the skin, but not due to actually high levels of bilirubin. And the main cause of this is hyperkeratinemia. That means high levels of beta carotene in the blood. And this is usually caused by excessive eating of foods that have beta carotene, like sweet potatoes and carrots. The main tip-off of this condition is that it spares the sclera. That means the sclera is not going to be yellow. So if you have a patient who comes in with yellowing of the skin, and you're like, is this jaundice or not? But they tell you that the sclera is not involved, it could be a good tip-off to pay attention for this condition as the cause. But in reality, of course, if we're suspecting it, we're going to check labs to check the bilirubin level because, again, remember, very important takeaway, true jaundice means high levels of serum total bilirubin. That's the literal diagnosis, the definition of jaundice. The patient's total bilirubin levels are high. And as a reminder, total bilirubin is the sum of the unconjugated and the conjugated types of bilirubin. And when we check lab levels, the unconjugated level is called indirect, and the conjugated bilirubin is called direct bilirubin. So that's how the lab reports it. So that means that the causes of jaundice can be broken down into three buckets. Those that cause high levels of indirect, aka unconjugated bilirubin, those that are caused by high levels of conjugated, aka direct bilirubin, and then the final category is causes that lead to high levels of both direct and indirect bilirubin, and those are known as mixed hyperbilirubinemia. And now in the rest of this video, we're going to go through all of these different buckets. All right, so now let's take a look at this diagnostic algorithm. How are you going to approach a patient on a test question that has jaundice? So first, we're going to confirm that this is true jaundice by high levels of total serum bilirubin, so the T-bili is elevated. And then the next question you should ask is this T-bili elevated because the indirect bili is elevated over here, bucket 1? Or all the way over here, is it because only the direct bili is elevated, bucket 2? Or are they both elevated? Is this a mixed hyperbilirubinemia? And the reason this is important is once you make this determination, then you can quickly narrow down your cause and your differential diagnosis based on which bucket you're in. So if you're in bucket 1 right here, if only the unconjugated bili is elevated, that means that your problem must be some kind of insufficiency in the conjugation. And the only two possibilities are hemolysis, because you're making too many red blood cells and overwhelming the conjugation capacity, or there's something wrong with the UGT enzyme's action. There's some deficiency there that it can't conjugate. So you've narrowed it down to these two possibilities. On the other hand, if your patient in the test question has only direct bili that's elevated, that must mean that the only thing that's going on is that you're having problems with excretion. So there's insufficient excretion of the conjugated bilirubin. It's getting trapped. And this conjugated bilirubin, the conjugation is happening in the liver. So it's either getting trapped in the liver itself or in the bile ducts. So once again, you've narrowed down the cause to only these two possibilities based on recognizing the lab value. Then finally, if both are elevated, that means that you have a problem with both conjugation and excretion. And since the liver is the only place where both of these processes happen, then there must be a problem with the liver itself, like hepatitis or cirrhosis, and you've quickly figured out the diagnosis if it's in this bucket right here. So now what I'm going to do in the rest of the video is to go through the causes in each of these three buckets in a little bit more detail. All right, so now let's talk about the causes of jaundice in bucket 1. So here we have indirect hyperbilirubinemia. That means we have high levels of unconjugated bilirubin. The conjugated bili levels are fine. Remember, the problem here is that we have some kind of an insufficiency in conjugation. That's why these levels are backing up or becoming elevated. And there are three main causes for this. So number one is hemolysis, especially when it is extravascular, meaning that it occurs in the spleen, not within the blood vessels. And that's because the spleen macrophages are what's responsible for breaking down the red blood cells and their heme into bilirubin. That's how unconjugated bilirubin is generated. So if you have a hemolytic disease, that means that there's some kind of a defect or injury to the red blood cells. Therefore, you're going to have excessive hemolysis, so extra breakdown of those red blood cells. That means extra breakdown of the heme and extra generation of the unconjugated bilirubin right here. And this is going to overwhelm the capacity of that UGT enzyme to conjugate. Therefore, this is going to lead to buildup of unconjugated bilirubin. The conjugated levels aren't going to go up that much because the UGT enzyme can only do so much. Therefore, the unconjugated is going to back up and levels are going to increase in the blood. A couple of examples of this are sickle cell and G6PD deficiency. These are a couple of the more common hemolytic diseases that you're going to see. And one that I want to mention especially is one called hemolytic disease of the newborn. And in this case, there's a blood type mismatch between the infant and the mom. Therefore, maternal antibodies are going to form against the newborn's red blood cells, and they're going to actually attack those red blood cells, cause hemolysis in the newborn, and lead to excessive buildup of unconjugated bilirubin and jaundice. And I talk more about this in a video that I actually have titled Hemolytic Disease of the Newborn, so you can check out that video to learn more about this. So that's cause 1 right here when you have hemolysis, so you're just producing too much unconjugated bilirubin. Now, cause 2 is a little different because here the problem is with the UGT enzyme. So there are inherited hyperbilirubinemias where there's just inherited enzyme deficiencies. And in 2 of these, there's a deficiency in the UGT enzyme. Remember, this is the enzyme that's responsible for conjugating bilirubin inside of the hepatocyte. And these two syndromes are Gilbert and Crigler-Najjar. Both of these are autosomal recessive, and in both of these, the UGT enzyme is deficient. The main difference is that deficiency is minor in Gilbert, and therefore these patients are only going to have mild symptoms, whereas the deficiency is severe or major in Crigler-Najjar, and these patients can have more severe symptoms. And I have a separate video that's titled Inherited Hyperbilirubinemias, so you can check out that video to learn more about Gilbert's and Crigler-Najjar. And then finally, the third common cause here of indirect hyperbilirubinemia is a condition known as benign neonatal hyperbilirubinemia. This is also called physiologic jaundice. This is the old term that we used to call it when I was a med student and a resident, and now it's changed to this name, but you're still going to hear this term as well. So I just want you to be familiar with it. You may still see it when you're studying. But the bottom line is that what this is describing is that most newborns are going to have some level of jaundice, some level of hyperbilirubinemia, and this is caused by high levels of unconjugated bilirubin. And this is typically physiologic because newborns typically have an immature UGT enzyme. It takes a couple of weeks for that UGT enzyme's activity levels to ramp up to normal. Therefore, early on, because of this immaturity, it can lead to some high levels of unconjugated bilirubin. A second cause here is that the fetal red blood cells have an increased turnover. So that means that there's going to be a faster breakdown rate of red blood cells, which means a higher generation of unconjugated bilirubin, which also can contribute to this finding. And then finally, the GI tract of newborns are sterile. That means that they lack the bacteria that are normally responsible for metabolizing and getting rid of that bilirubin in the GI tract. So this could lead to some excessive recycling of the unconjugated bilirubin, which could also lead to this condition right here. So these are the three main causes that you're going to consider when you see someone who comes in and they have an isolated indirect hyperbilirubinemia. All right, so now let's talk about causes of jaundice that happen for the opposite end of our algorithm. So direct hyperbilirubinemia, that means that problem is too much conjugated bilirubin. So the unconjugated bilirubin is fine. What happens is we're conjugating it, no problem. But after the step of conjugation, this conjugated bilirubin gets trapped and cannot get excreted, leading to high levels of conjugated bili. And there's two places where this can get trapped, either in the hepatocytes or in the bile ducts. So let me show you how this works here. So let's remember this is the hepatocyte where the unconjugated bilirubin becomes conjugated to form conjugated bilirubin. Then from there, the first thing that has to happen is that the hepatocyte has to excrete it from inside the liver cell into the bile canals right here. And then these bile canals are going to come together, form the bile ducts right here, and eventually drain into the common bile duct and then into the small intestines, where conjugated bilirubin is just then going to get metabolized and eventually eliminated through feces. So this is how it normally is supposed to happen. But what happens in this situation with direct hyperbilirubinemia is that this conjugated bilirubin can get trapped. The first place that it can get trapped is within the hepatocyte itself, so right inside of here. And the way that this can happen is primarily through two types of inherited hyperbilirubinemias. So this is going to sound familiar because we talked about inherited hyperbilirubinemias on the last slide. The difference is that those were problems where the enzyme deficiency led to a defect in conjugation. Here, the enzyme deficiencies that are inherited leads to a problem of the hepatocyte handling and excreting the conjugated bilirubin. Therefore, this problem here is going to lead to high levels of conjugated bilirubin. The main one you should know about is Dubin-Johnson. So here, the defect is in this hepatocyte exporter protein MRP2 that's responsible for dumping the conjugated bilirubin from the hepatocyte into the bile canaliculi. So because this enzyme is defective, this conjugated bilirubin is going to build up and back into the circulation, lead to high levels of conjugated, aka direct bilirubin. The other one is Rotor syndrome. This one is more of a generic defect in conjugated bilirubin storage and excretion within the hepatocyte. Similarly, these levels are going to build up, back up into circulation, and lead to high levels of direct hyperbilirubinemia. And in the video that I mentioned on the last slide, titled Inherited Hyperbilirubinemias, I also go over both of these diseases in more detail, so you can feel free to check it out. Now, the next place that conjugated bilirubin can get trapped is in the bile ducts. So let's say that there was no problem with our hepatocytes getting rid of their conjugated bilirubin. They dumped it into the bile canals. Remember, these bile canals now come together, form bile ducts, and these bile ducts have to function properly, come together, and drain into the small bowel to get rid of this conjugated bilirubin. So this is another place where conjugated bilirubin can get trapped within the biliary tract, and that's when you have a biliary tract issue that leads to this trapping and impairment of drainage to the bile ducts. And I try to organize these into three different categories to make it easier for you to learn and remember. So the first category is when there's a biliary tract absence. This is a congenital absence of the biliary tract. This is known as biliary atresia, and I actually have a separate video that covers this topic. The second category is when there's disease of the biliary tract. There's two main ones, and both of them are autoimmune. These are primary biliary cirrhosis and primary sclerosing cholangitis. and I have a separate video that compares these two and talks about the details of them. But essentially, in both of these conditions, the onset is in adulthood, and the immune system attacks the biliary tract, leads to impaired drainage, and can lead to direct hyperbilirubinemia. And then finally, the third category, this one's the most common. Here you have biliary tract obstruction due to a mass. So some kind of a mass effect is actually blocking the bile ducts here. And the most common one that we see clinically is a gallstone in the common bile duct. So imagine you have a big old gallstone that's sitting right here in the common bile duct. Then all of this green is going to back up right here and lead to backup of conjugated bilirubin. Another one that's super high yield, both clinically and also for exams, is a tumor. So, tumor anywhere along the biliary tract, like in the liver or the bile ducts, can lead to this problem. But one that is super high yield is a tumor in the pancreatic head. And the reason that's high yield is because it's related to anatomy. And you should know that the common bile duct goes through the pancreatic head as it enters the duodenum. So, a tumor in the pancreatic head can actually cause an obstruction of the common bile duct, leading to direct hyperbilirubinemia. And the third one is a liver fluke, which is basically a parasitic worm. It is not common in the US, but it is very common in East Asia. Its name is Clonorchis sinensis, and this one has a propensity to infect the bile ducts, and just by its presence and infection here, it can lead to obstruction and high levels of conjugated bilirubin. Now, you may be wondering, are there any other clues on a test question that or a presentation that can lead me to know that this is going to be a direct hyperbilirubinemia? In other words, there's a problem with excretion of conjugated bilirubin, and there is. So the patient presentation is typically going to be with pale stools and dark urine. The reason for the pale stools is because conjugated bilirubin normally, once it enters the intestines, it gets converted to urobilinogen and then into another byproduct that actually gives the stool its brown color. But in this case, case of these direct hyperbilirubinemias, we actually don't have any conjugated bilirubin entering the small intestines. Therefore, it can't be metabolized to this byproduct, and therefore the stool is not going to get its brown color. That's why they have pale stools. The reason for the dark urine is also easy to explain. When you have high levels of conjugated bilirubin backing up into the circulation, some of this conjugated bilirubin is going to eventually make its way to the kidneys where it's going to get filtered and end up in the urine, and that's going to give the urine the dark color. And then the final clue is going to be that these patients will have low levels of urobilinogen, and that's once again super easy to remember because urobilinogen is made in the gut from the metabolism of conjugated bilirubin. However, again, in these patients, you don't have conjugated bilirubin in the gut, therefore you can't make urobilinogen, and that is why these patients will have low levels of urobilinogen. So on test questions, these are very common hints that are going to drive you to know that the patient's cause of jaundice is in this bucket right here that we just covered. All right, so final category is mixed. So here we have both high levels of indirect and direct bilirubin, so high levels of both unconjugated and conjugated bilirubin. And this is very straightforward because the pathophysiology means that you must have a problem with both conjugation and excretion of bilirubin. Both of these processes must be impaired. That's why you have high levels of both of these. And the only place in the body where both conjugation and excretion of bilirubin happens is the liver. Therefore, generally, the main time you're ever going to see mixed hyperbilirubinemia is when there's some kind of a liver injury, because that's the organ that's responsible for both conjugation and excretion. And the acute form of liver injury is typically called hepatitis. And if that goes on for a long time and you have chronic liver injury, then that can lead to cirrhosis. And therefore, the main conditions where you're going to see this very high levels of both indirect and direct bilirubin is in hepatitis and cirrhosis. All right, so now let's summarize by getting back to our diagnostic algorithm for jaundice just to revisit it. So let's start over here with our indirect bilirubin bucket right here. These are high levels of unconjugated bilirubin, so the problem was insufficient conjugation. So we had increased hemolysis that was like in sickle cell, G6PD deficiency, hemolytic disease of the newborn, and benign neonatal hyperbilirubinemia, where we had a physiological increase in fetal red blood cell turnover. Then the other category here was due to impaired action or a deficiency of the UGT enzyme. The main examples we saw there were the hereditary hyperbilirubinemias, so Gilbert's and Crigler-Najjar, as well as once again our benign neonatal hyperbilirubinemia, which is physiologic jaundice. Remember that the neonatal UGT enzyme is immature, and therefore that falls in this category as well. Let's go on the other side where we have high levels of direct bilirubin. So the conjugated bilirubin is trapped. And if it's trapped in the liver, the main two cases we talked about there were the inherited hyperbilirubinemias of Dubin-Johnson and Rotor syndrome, or it can be trapped in the bile duct. So you can have a congenital absence of the bile duct, such as biliary atresia. You can have biliary tract disease like primary biliary cirrhosis or primary sclerosing cholangitis, or you can have a biliary tract obstruction by a common bile duct stone, pancreatic head cancer, or a liver flukes. And then finally, the last category was when you had high levels of both direct and indirect, and we said that the problem here must be within the liver because we have problems with both conjugation and excretion, and so this was due to hepatitis and cirrhosis. All right, that's it, and that's all. As I said, I covered a lot of different diseases in this video that cause jaundice, but if you want to learn more about them, I have separate videos and I've linked a few of them here, so you can feel free to check out the ones that you want to learn more about. And also, if you guys enjoyed this video, don't forget to like and also share it with others, and also subscribe so that you don't miss out on upcoming content. But for now, thank you for watching, and I'll see you next time.